Good afternoon, everyone. Lisa Homa here. Hope you're having a great day. On to week 4 lesson, Contemporary Issues in Nursing. The objectives in this lecture are to discuss the most prominent contemporary issues impacting patient care in the U.S., to provide culturally and linguistically competent care to our patients, and to identify a cultural group and determine the holistic, cultural, and spiritual beliefs of that patient and family and healthcare setting. On to Chapter 21. Cultural and linguistic competence. Individualizing the care nurses provide to patients is highly dependent on a thorough understanding of each patient's cultural identification. Think to yourself, consider your own cultural biases and how they affect and impact your nursing care. One way to find this out is to understand your implicit bias. If you just Google implicit bias test, you'll be able to find it and you'll learn a lot about yourself. I will explain in detail more about implicit and explicit bias as we move through the presentation. Also, it's important to understand the need to recognize cultural implications in planning and implementing your nursing care. And we're going to talk a little bit about a cultural assessment tool. So if you look in the course under the lesson 4, there is a downloadable cultural assessment tool that'll help you with your practice. Also, we need to treat patients with dignity and respect and to use sensitivity in providing culture competent care. The ANA Code of Ethics posits the need for the nurse to be sensitive to individualized needs. What is universal to every patient, regardless of where they come from, who they are, is that every person has the right to universal health care all across the board, regardless of your differences. The Office of Minority Health, the OMH, defines as a set of congruent behaviors, attitudes, and politics that come together in a system, agency, or among professionals that enables effective work in cross-cultural situations. As the largest group of care providers, nurses are at the center of providing culturally competent patient care. Linguistic competence, on the other hand, is defined as the inclusion of culturally appropriate oral and written language services to individuals. With our discharge instructions, we should ensure the patients have both the written and printed materials in their culturally appropriate language. The IOM suggests the 4 C's of culturally sensitive care. Ask the patient, what do you think is wrong, as a way of understanding their perception of what they think is wrong. The second C is cause. What do you think caused your problem? The third C is cope. How do you cope with your condition? How does it impact or affect your daily routine or life? The fourth C is concerns. What concerns do you have regarding your condition? Barriers to cultural and linguistic care. There are 2, provider barriers and system barriers. Provider barriers are just those that anyone on the healthcare team can create a barrier, including lack of information about an individual's cultural customs or traditions. A system barrier are those that exist in an agency because an agency's structure and policies are not designed to support cultural diversity. For example, barrier can be the way that we offer visiting hours to patients and family, and if family members are allowed to stay with their loved ones. Nurses can intervene by 1, finding out more about the culture, taking it to a hospital committee, and begin work on changing some of the protocols and family visiting policies so that loved ones can follow their cultural traditions and be with their loved ones to support them throughout their illness. Linguistic assistance. When possible, use certified interpreters. In a perfect world, we would have certified interpreters with us 24/7. Some institutions use an iPad that we're able to dial a number and have linguistic assistance with us 24/7. It isn't always possible, especially on night shift. It's not always possible for family to have additional family members with them that can also interpret. When someone, like a family member, interprets for them, they're not certified, they call that ad hoc interpreting. Not the best scenario. Also, it's important for nurses to provide written material in the patient's preferred language. Disparities. Healthy People 2020 goal is to achieve health equity, eliminate health disparities, and improve health in all groups. In 2017, the National Healthcare Quality and Disparities Report showed that individuals at or below 100% of the federal poverty level experience the worst access to care compared to high-income groups. Inequalities in income and education are at the root of many health disparities. Health disparities can be a result of differences in socioeconomic status, race, or ethnicity. They're believed to be the result of interaction among genetic variations, environmental factors, and health behaviors. When these incidences occur, it causes patients not to want to seek out the healthcare system when they are having issues. The IOM report on disparities occur from healthcare professionals, and what they identified were unequal treatment, conscious or explicit bias. Explicit bias is an individual's preconceived judgment or belief for or against something or someone. Unconscious bias, or also known as implicit bias, is an unintentional judgment or belief for or against something or someone. A person may not even be aware of the attitude or even have control over it. This impacts the quality of care and direct relationship with disparities. In 2017, the nursing workforce showed that minorities accounted for 19.3% of all RNs in the U.S. It's important to ensure that cultural and ethnical diversity exists among not only nursing staff, wherever we are working, but also among nursing faculty. Across the U.S., there's only 15.8% of all nursing faculty that are from groups underrepresented in the nursing profession. Project Implicit 2018 offers a test that assesses and determines your implicit biases. Harvard has spearheaded the project. They included up on their website a free test that anyone can take so that you can understand your implicit biases. There's a link here in the PowerPoint, but there's also one under Lesson 4 in the course that you can go on to take your test. Spirituality and religion. What does the term spirituality actually mean to you? Does spiritual have a religious affiliation or being intuitive to the needs of others? What do you think it is? Is it being altruistic or understanding the uniqueness of others? Is it all of these things? Or is it something completely different? This is part of what makes the topic so challenging. The only thing we know about spirituality is there is no universal definition. What is spirit? Some people would substitute the word spirit with the word soul. So what does it mean to you? Spirituality is a universal concept relevant to all individuals. The uniqueness of an individual is paramount. Formal religious affiliation is not a prerequisite for spirituality. Any individual may become more spiritually aware during a time of need, like, for example, when they are sick. Definition of spiritual nursing care is intuitive, interpersonal, altruistic, and integrative expression that is contingent upon a nurse's awareness of the transcendent dimension of life, but that reflects the patient's reality. It's important for nurses to refrain from imposing their spiritual beliefs on patients, as spirituality is a very subjective experience and differs significantly from person to person. Religion is defined as a set of institutionalized beliefs and rituals, whereas spirituality can be defined as an individualized journey characterized by experiential descriptors such as meaning, purpose, transcendence, connectedness, and energy. For many people, religion helps to explain the meaning of life, suffering, health, illness. Religion may be one approach to spirituality, and spirituality may be a component of religion, but the two are very different concepts. Spirituality may bring meaning and purpose to life. It is often described in a secular perspective with concepts like love, honesty, truth, peace, and happiness. Spiritual interventions that nurses can do with a patient and family, if they are obviously open and it follows their beliefs. They can pray with them. They can be in just the mere presence with them, if that's acceptable. They can be part of scripture reading. They can provide a peaceful environment. They can provide meditation, music, offer pastoral care services, and also an inspiration of hope through positive affirmations. I don't know if you've ever did positive affirmations. You can Google positive affirmations and you'll get a whole bunch of them. And it's really creating positive statements over your life. People believe that it goes, anything said verbally out into the atmosphere will come back to you. Nurses can also actively listen to their patients if they want to talk about their spirituality. They can validate a patient's thoughts and feelings. They can clarify values with a patient. They can be sensitive and provide sensitive responses to patients about their beliefs and develop a trusting relationship by, again, being supportive, not judgmental, not sharing their own thing, focusing on the patient and family. How do we assess spirituality? There is a universal method for assessing spirituality. This is probably one of the most popular assessment tools. I'm not sure if you've been exposed to this before, but it's called, using the acronym FICA, it's the FICA model. F stands for faith, I, importance and influence, C is community, and A is address. I have included here in the PowerPoint, I've included the link to a spiritual assessment. There's also an article in the course that goes into more detail on how to perform a spirituality assessment. Special considerations with spirituality happen with end-of-life care. There may be very specific spiritual and religious practices that patients want to follow or we need to be respectful of during end-of-life care practices. Are there any garments, religious items, or rituals that are important to the patient and family during this time? What are practices of the patient's culture regarding care of the body and death afterwards? Often it's customary for nurses to wash the body and prepare it to go to the morgue. Perhaps that's not part of the cultural practice, or maybe the family would want to be part of that ritual. And then how should we treat the body? Do we wrap the body in a certain way? Again, we'd have to follow the lead of the family and what is the most respectful and follows their culture and their cultural practices most closely. Would the patient and family welcome a visit from a religious leader or member of the clergy during this time? And we have to talk about holistic care really briefly. The American Holistic Nurses Association, so our theoretical framework is holistic comfort theory, follow some of this because we look at the whole patient, not just from the physical perspective, but all aspects of that. All nursing practice that has healing the whole person as its goal. That's all holistic or holism means. We follow an attitude, philosophy, and a way of being, and the vital components of holistic nursing assessment are an identification of cultural and spiritual practices. I've also included in the link in the PowerPoint to a transcultural nursing assessment, so it follows holistic care, and there's also one in your course for you. And that's all we have today. Thanks for listening. Have a great day.